When your athlete is complaining of substantial dizziness or vertigo, I like to add a couple tests. So I will do a head impulse test to test their VOR again and be really clear in my own mind whether their VOR is normal. In the head impulse test, I'll be rotating the athlete's head back and forth about 15 degrees. You'll have them stare at your nose. Usually the athlete should be able to keep their focus on your nose, but as you're rotating them back and forth, if you see them need a compensatory saccade, then you know they have a vestibular disorder, either inner ear or vestibular nerve on the side that you turned their head when they had to do the saccade. Additionally, occasionally patients will get benign paroxysmal positional vertigo after a head injury. So doing a Dix-Hallpike maneuver can be very helpful in diagnosing that. You have your athlete sit on the table, lay them down over the edge of the table, slightly holding their head, turn their head usually first to the side you think is not symptomatic, having them look down to the side, tilt their head down to the side, and see if they develop torsional nystagmus. Usually there'll be a slight latency, but then they'll develop torsional nystagmus and feel the vertigo. Then you sit them up, and frequently the nystagmus will reverse in direction, then test the other side. So we're going to demonstrate those two techniques now. Now we're going to demonstrate the head impulse test. So basically, Holly, I want you to just stare at my nose. And I'm going to quickly move her head back and forth and try and make sure that her eyes stay on my nose. Ready? Mm-hmm. There was absolutely no extra movement of her eyes. They stayed right on my nose. There was no compensatory saccade, so that is normal. Now we're going to demonstrate the Dix-Hallpike maneuver, which evaluates for benign paroxysmal positional vertigo, particularly from posterior canal involvement. You want your athlete to sit comfortably on your table, and you have to judge the distance so that their head can come over the edge of the table. You're going to hold their head slightly below horizontal and turn them from side to side. Once again, if you have an idea that the athlete is symptomatic in a certain position, such that they say when they're lying on their right side in bed, they get vertiginous, then I would check the left side first. But for the purposes of this video, we're going to check this way so you can see what Holly's eyes look like. So Holly, when you're ready, if you'll lay back, I'm going to hold your head and turn your head to the right. And let me know if you're feeling any vertigo or dizziness. I'm just looking for torsional nystagmus of her eyes, which is not there. Her eyes are perfectly still. And usually there'll be a little latency if it's going to come. And if you wait 30 seconds and you don't see it, then you can have the athlete sit up. And then you would repeat it on the other side. After the patient sits up, usually their legs will still be extended on the table. You want to look for reversal of the nystagmus. So you just take them through their eye movements again if they had nystagmus and they were down. There are a lot of patients that say they're dizzy when they are down and up, and if I don't see the nystagmus, then I usually don't think they truly have a positive test. Sometimes you need to refer them to vestibular therapy if you want to do further testing if you're not sure, and they'll put Fresnel lenses on the patient, which will blur their vision and accentuate the nystagmus. Once you've done one side, you sit the patient up and then lay them down and repeat the procedure with their head turned the other way. And that's a Dix-Hallpike maneuver.